Everybody. At the outset, thanking V for calling me here. And I'm just waiting for my own pen drive thing to be, so the slides would. Huh? This is not from. Same? Yeah, okay, fine. Happy to see some of my close friends here in the audience. And I am like a son in law in a woman's conclave because one is you're all endocrinologists. And I always feel physicians know theory and thing much better. Surgeons are relatively poor at that. So I'll touch on the few practical things. Dr. Sambit and Dr. Sahana, you all have made an excellent presentation, Lot of my workload has been taken out. But I'll start exactly from where you all stopped. That many times this evaluation which you mentioned is not done. And I'm not being preachy over here. The only thing is that with a huge practice, lot of people waiting in the waiting room, who is going to evaluate the foot in so much detail? And that is where the problems start. So it is more of a practical orientation as what you all are supposed to do as physicians or endocrinologists in a surgical setting. So how do you proceed this? This one? Yeah. I'll start with some very simple cases. This patient had a small sinus. Can you see this? This sinus is not even seen. This is the part where the sinus was. And he was going to his physician regularly saying that there is some discharge from the foot. As it was, some ointments were given, some antibiotics were given, nothing was actively done. He came to us. I'm not saying we did something great. As a foot surgeon, the first thing I would do is an X-ray. And needless to say, when this X-ray was done, it showed osteomyelitis. There was complete destruction of the bone over here. And this patient landed up with a fifth toe amputation. Now, fifth toe amputation is not really going to affect this patient's life, but his primary question was, I was going to my physician for almost 3 months, telling about this sinus. Nothing was done at that time, and now I have landed up with an amputation. So, diabetic foot sometimes can become medico-legal as well as social problems. A simple thing like sinus, but missed only because an X-ray was not done. And something similar with the previous presenters had said. This was a callus ulcer, again treated with antibiotics for about 1.5 months. Needless to say, this patient comes to us, it's not rocket science, all I have to do is an X-ray, and that X-ray shows again an osteomyelitis, and the patient lands up with an amputation. So many amputations could have actually been avoided. We are talking of staggering figures, and that is why I'm thankful that a surgeon is invited to an endocrinology conference, that we have 90 million or 9 crore diabetics. This number keeps increasing. When I started giving my talks about 10 years back, it was 3.5 or 35 million diabetics. Now it's 90 million. Probably the number is much, much higher. So we are talking of a workload of 180 feet at risk, 180 million feet at risk. And if this is the volume which we are going to address, this is something which is extremely important. More than 1 lakh of amputations are done in our country. This is the statistics for India. And when we are talking of these 1 lakh amputations, it is not toe amputation. We are talking of either a transmetatarsal, that is the midfoot amputation, or a below knee or an above knee amputation. That means major 1 lakh amputations are done. This is the slide which I have borrowed from somebody else's presentation. This gentleman has been a professor of medicine at a Patna Medical College. And when all resources probably were available, knowledge was available, care was available, and in spite of that, if this gentleman has landed up with a bilateral above knee amputation, I think diabetic foot is not something which can be ignored. Speakers have talked about this, and you all have presented all this very well. But the two things to be mentioned are, there are two pathis with which a diabetic will always live through the life. If the pati is not good, we can throw away the pati. But this microangiopathy and neuropathy are the two pathis which are going to live with this patient, and therefore all this has to be taken care of. I'm not going on to this algorithm now. There are multiple classifications, but again, as I told you, I'm trying to stick to the practical aspects over here, because the take-home message will be how we are going to protect the foot. There are Wi-Fi classifications, Wagner's, which Madam has talked in details. There is sepsis 6 pathway, the ideal group, a lot of things which in conferences look very nice when we talk of a lot of classifications and all. But what is important now, and that is my talk, as to what are the pitfalls in a diabetic foot. Where are we faltering? Where are the problems? So I'm talking of some change of concept. I am a trained general surgeon. Last 15 years I am into diabetic foot. And people ask sometimes, what different do you do? Nothing. That cannot be something different we are doing. It's not some high robotic surgery. It's not rocket science. But it is different concepts. And these different concepts are something which I shall talk about just now. The first thing today which has come up is a concept of biofilm. And if there are students, biofilm can come almost as a short note in today's exams. And what is a biofilm? These are all bacteria, different bacteria. We are all sitting in this room. We are protected by this roof. So the biofilm protects the bacteria and they start getting cross resistance. That means if one bacteria sitting by my side is resistant to augmentin, today I am susceptible to amoxiclav. Because of him, I also start becoming resistant to amoxiclav. So this is the resistance which is seen by all the bacteria sitting under that biofilm. And all we need to do is, as a surgeon, I have to scoop out that biofilm. I have to expose a new clean tissue below and the wound will start healing. If you keep dressing on the biofilm, the wound is not going to heal at all. For the non-surgeons, you need not have to scoop because it's a surgical procedure, but there are ultrasonic debriders, there are Versajets, there are all these things which can be used in the clinic. But the first concept or the pitfall is, if there is a biofilm and if I keep dressing, this wound is not going to heal. The next is the concept of angiosomes. Something simple. If there is a theft in this area, Andheri area, the police station is Andheri police station. You can't go to Dadar to lodge a complaint. Similarly, here is a particular blood vessel which is supplying a part of the foot. And this angiosome concept, which is now in the last 5 to 7 years achieving more and more importance, has changed our approach to diabetic foot. So whenever there is a vascular intervention done through a vascular surgeon or an IR, that's an interventional radiologist who can do that, we have to remember that a particular artery, if it is the posterior tibial artery, it's going to supply the medial aspect of the foot, the sole of the foot, the plantar aspect of the foot. So if there is a problem on the medial side, it's no point me having a good vascularity on the lateral side. And with this, my confidence in my surgeries increase, because if there is a toe amputation toe gangrene over here, and if the angiosome is patent or the angiosome is well perfused, then I can just do one toe amputation. I'm almost sure about the results. Whereas in a similar case, if there is some gangrene and I find that a particular angiosome is not perfused, that means the blood flow oxygenation is not good, then I straight away go ahead with a 4-foot amputation. It's just telling the patient. Otherwise, diabetic foot surgeries fall into disrepute. People say, pehle mera ek nakhun kata, fir toe kata, fir 4-foot kiya, then below knee kiya. That is because a concept has to be applied as to how wound healing would take place. So the angiosome concept is now telling me where I should operate or what I should operate. The next thing where life has changed for a foot surgeon or a diabetic foot surgeon is the application of vacuum assisted closure. I'm sure all of you all must have heard of this, and I'm sure at a lot of centers this is done now. By putting a vacuum, a simple thing, a simple device where it keeps sucking out the exudate, also allows angiogenesis, neovascularization. Healing is far, far better when vac-assisted closure is done. It has changed the approach of a foot surgeon to non-healing ulcers. Then there are things like stimulan. I'm not going through these videos, but these are calcium impregnated antibiotics. Especially if the bone is affected, I have to either give antibiotics like linezolid for 6 weeks, 3 months, which really causes a lot of problems with the patient. Here, once I get the culture sensitivity, if the bone is infected, I literally stuff the wound with these calcium impregnated these beads, and it has got phenomenal results. So Being aware of the newer, simpler modalities which have come has again changed a lot of approach to diabetic foot. Large ulcers today, we have dermal matrices. That means the skin is composed of the epidermis and the dermis. When I do a skin graft, I am taking a superficial layer of the skin and applying it on the foot. Here, there is first a dermal layer which is applied, especially when tendons are exposed, where earlier we used to say tendons are exposed, tendons are desiccating, I may have to amputate. No longer today. Today we have a dermal matrix which is applied, which will cover the tendons, and then I can actually do a skin graft after this. So this is again a thing which is now coming up in a big way. And for people where a vascular or a microvascular surgery department is available, then things like free flap is something which has again changed the thing from an amputation to a non-amputation. See this, a bad foot, debrided over a period of time. This patient needed multiple debridements, he needed vacuum therapy, and then this was a wonderful area which was ready. But maybe 10 years back, at the end of that red thing also, this patient would have landed up in a problem. Why? Because had I put a skin graft, once the patient would start walking, that graft would ulcerate. Because see, such a large area on the weight-bearing area. Now, with this microvascular surgery, they would harvest somewhere from the abdomen or the thigh, and with the blood supply, put a graft on that area, which gives a good, nice, puffy, spongy layer over here, that this patient is now a walking patient. I couldn't get that video over here. It's about 3 years, the patient is walking without any ulceration, but the credit for not getting an ulceration goes to the patient, because probably he is taking adequate and due care of this particular problem. So at the end of it, what we actually need, in spite of all these high things, is simple tips. You all have excellently described how the patient is to be counseled, that if the patient does not wear a footwear which looks like an MCR thing, with an MCR insole, that's microcellular rubber. You know, we get so many of affluent patients, the moment we show them the footwear, they say, nahi, mar jaunga, lekin ye footwear nahi pehnunga, ye bhikari ke jaisa dikhta hai, leprosy ke jaise dikhta hai. But we almost feel like telling that, okay, you land up with an amputation and then come with crutches. So, when they do not want all this, the important thing is that we have to counsel them. And these are the simple tips which actually make or go a long way in treating patients or taking care of the patients. There was a St. Vincent's declaration years back, I really wouldn't remember the year, where they had a conclave, and then they decided, or the declaration was, that it is only because of counseling that a diabetic foot patient or diabetic foot injury could be prevented. Of course, the other things like glycemic control, foot care, etc. But knowing what your foot is something important. And they had estimated that if we follow this, the amputation rate will come down to 50% in 5 years. That declaration was more than, I think, 10 or 15 years back, and our amputation rate has gone not down, but it has gone up by at least 10 times, leave alone getting to half. We always thought diabetic foot was a nice thing. This is just to entertain. Some volume, please. I always thought diabetic foot, I would get to see some nice legs and nice feet like this. But in our clinic, I have never got the opportunity to see these legs. What we see is dry legs, shriveled legs, deformed legs, callus with an ulcer, here gross deformity over here, a callus over here again. If not treated, this is the callus ulcer. So leave alone beautiful feet, this is what we keep seeing. And this is the end stage Charcot's which you all had shown. That this is just a bag of bone. This person is not having a walkable foot at all. The moment this lady walks, this is going to be ulcerating. So all we need to do is test to evaluate. Again, wonderfully explained by the previous speakers. Just going through this biothesiometry, Doppler. But here I just want to show one more thing in Doppler. Volume, Motakran. Sorry, my time is over. I'll get another 5 to 7. How do you stop that? Right. And then you do, in addition to Doppler, I wanted to show, we couldn't get the video loud enough, that Doppler itself, a handheld Doppler, if you do 100 Dopplers, just on that you'll be able to say whether the blood flow is going to correspond to a triphasic, biphasic or a monophasic blood flow. So just a Doppler is an important test, but you all need not have a Doppler. Even if you palpate the dorsalis pedis and posterior tibial, that is good enough. But believe me, again, this is not too, this is just since it's knowledge sharing I'm saying. I've had surgeons who are doing this, got into trouble because, and I'm talking of medico-legal trouble, because a Doppler test was not done preoperatively, and in the notes also DPPT, well heard or well felt, was not mentioned. And there were medico-legal cases, and we had a hard time to formulate as to how a patient can be protected. Because, see, amputation becomes a very, very sensitive thing. And then if you really want to go further into a diabetic foot clinic, you can have ABI, an ankle brachial index, which is, I think now this is not moving. Yeah, sorry. Okay, fine. An ankle brachial index is done. If you want to evaluate the patient further, then transcutaneous oxygen. This is important for a surgeon to decide the level of amputation. And a mapping of the foot is important. So about these various areas where this patient can have a dynamic scan, and frankly, even I don't understand too much of this dynamic scans because there are too many readings which come. But what is important is, at the end of this scan, you don't need rocket science to know that these red areas are high pressure points, and if you don't offload these areas, today, tomorrow or day after, this patient is going to land up with an ulcer, and ulcer is going to be a precursor to an amputation. So all these scans are important, provided you can give the right type of footwear. Many times, this footwear are not easily available. And if they are available, the person has resistance in wearing those. Because see, these are heavy footwear. As you said, there has to be a planter, a counter behind, a strap behind. They should not have that thumb in between. So all these things are important, and people are reluctant. But if they do not comply with this, ultimately you have to tell them it is going to be a precursor to ulcer. Simple honeycomb footwear are available where, wherever there is an ulcer, you can take out those parts from the honeycomb so that that particular part can be offloaded. And again, as I told you, I am going to show this video to you because I was told there are students, so I thought I'll show a few naughty videos. That one thing over here is, in the last 3 or 4 years, I had got a lot of invites for setting up a diabetic foot clinic. You know, talk on how to set up a diabetic foot clinic for physicians or for surgeons. And there are so many people who are now coming and visiting as to how to set up. And I always show this to them, that do not come with this idea of a setting of a diabetic foot clinic. Excuse all this. This is just to show that we would all like to have nice feet at our disposal. But no, what we are actually seeing in a diabetic foot clinic is far from this. This is what we shall see. And not only this, this has been one of my patients where the whole foot was infested with maggots. So, for endocrinologists, physicians, diabetologists, if you all are prepared to experience all this, if you all are prepared to see and treat and touch all this, then I think it is worth starting a diabetic foot clinic. And when we touch patients' feet, you know, many times patients are a little reluctant. Doctor, pair ko haath lagate and that type of thing. And we say that when the Lord also had cleansed somebody's feet, I think we as doctors would be doing a great service by just touching or examining a patient's foot. Because diabetic foot, believe me, is not rocket science. At the same time, it is not a simple thing to treat, because an amputation becomes a very, very sensitive point for the patient, and therefore be careful. If you touch the foot wrongly, then it's like a big kick. Thank you, ladies and gentlemen. I always feel that diabetic foot slides, we all show dirty slides, gangrene, smell, pus, maggots, and especially when you all give me a pre-lunch session, I think log kaise curse karte rahenge for showing these slides. And therefore, I want you all to go with a little happy memory. I shall show you the best feet in the world. These are Jennifer Lopez's feet. So see them, go with a good memory of diabetic foot. Thank you.